Thank you very, very much for this nice words and this kind introduction and the invitation to be present here with you, even if it's only virtually. I'm really, it's really a pleasure for me to be here. So you invited me to give some ideas about neuropathic pain, as you already mentioned. And I hope you can see screen now. Is that okay? Good. So this is the title you suggested, so chronic neuropathic pain classification, but I think most of the classification issues were just mentioned by Ralf Baron. Diagnosis, how to diagnose neuropathic pain, and obviously the management, what is new and what do we have to do if it comes to the treatment of neuropathic pain. So what I would like to do is I would talk a bit about the underlying mechanisms of pain generation, because I think it's very important to understand the neuropathic pain mechanisms, because then we can perhaps target our treatment approaches, so the drugs we will use to these mechanisms, and we can understand why we are using these different drugs in these different states. So this is just to mention the people who are doing all the work back in Germany. So you know that I'm based in Kiel, which is in the very, very north of Germany. And so this is the team, my lab, and also the conflicts which I have. And they, again, do all the work except this one who's giving the talks and traveling and so forth. So this is the agenda which I would like to go through today. I divided my agenda in 3 parts. So I would like to convey some ideas about the obligatory. So what do we have to know if it comes to neuropathic pain? Briefly, the definition and some overlap, obviously, with Ralf Detlef's talk, as he already mentioned. But then coming to the tools we have to diagnose neuropathic pain. So the signs and symptoms of neuropathic pain, which are so characteristic, and we all have to know these signs and symptoms to make the right diagnosis. And then the use of the rational treatment strategies, as I mentioned earlier. So why are we using some medications, some drugs, and how do these drugs act on the different mechanisms? Then followed by some new ideas, which is really a hot topic these days, is the personalized treatment strategies in neuropathic pain. You know that personalized or individualized or precision medicine is very, very en vogue in many areas of medicine, in particular in oncology. But I think we also can adopt this concept and practice this in our neuropathic pain field. Some words about disease modification, and then I would love to talk a bit about killer cells, about inflammatory reactions in neuropathic pain and chronicity. And the last bit is about the obsolete, so what we should not do in the treatment of neuropathic pain, so what should we avoid? So the obligatory number 1 is the definition. What is neuropathic pain? And I think you all know this. This is a pain which arises as a direct consequence of a lesion or a disease. So this is very important. So you have to find a lesion or a disease to diagnose neuropathic pain. And this should affect the somatosensory system. And this can be in the peripheral nervous system or in the central nervous system. And I just brought some ideas about etiology and about this classification. So if it comes to peripheral neuropathic pain, so we stated peripheral neuropathic pain, and you found this in the ICD-11 classification as well, as Ralf Baron mentioned. But we distinguish didactically between the focal nerve lesions, which occur in the periphery, and I listed some examples here: phantom limb, zoster. We heard about zoster and postopedic neuralgia, but also others, which you can see and read here. And then there are, again, peripheral neuropathic pain states, which have a generalized distribution, and we call them, as neurologists, polyneuropathies. And here are some of the etiologies which are very often associated with polyneuropathies and very frequently with painful polyneuropathies. And then, as we mentioned earlier, the lesion also can occur in the central nervous system, and this is very often associated with stroke, for example, in the thalamus, spinal cord injury, or even multiple sclerosis. So this is the etiology-based classification of neuropathic pain. So what are the characteristic signs and symptoms of neuropathic pain? So what do we have to ask our patients for symptoms, and what do we have to assess for signs in neuropathic pain states? Some examples. Many patients describe a burning sensation. So this seems to be very typical for neuropathic types of pain and can be used to distinguish this from other types of pain like nociceptive pains and so forth. Also these are ants, ant crawling, prickling, tingling sensations are very typical and characteristic. Numbness is typical as well. And then if it comes to the assessment, you see here a pain which is elicited by a very, very light touch to the skin. A stimulus which normally does not induce any pain, but in neuropathic pain, it might lead to a severe pain. The same holds true for a pinprick stimulus, which might be much more intense perceived by the patient as in normal volunteers or in other pain states. So these are the evoked types of pain, which also are characteristic for neuropathic pain. And you might know that we developed a special questionnaire just addressing with these questions. This is in German now, but we have this translated in many, many languages. These questions are addressing exactly these symptoms of pain which are typical for neuropathic pain, and therefore we can use this to identify and to screen for neuropathic pain entities. This questionnaire is called the Pain Detect questionnaire. So now let's switch gears a little bit and go to the treatment strategies and the rationale behind our treatment strategies. So just imagine a primary afferent neuron. So this is a nociceptive fiber over here. This is the spinal cord, the second order neuron in the spinal cord, and this is the brain. So what happens to the primary afferent neuron, to the pain fiber, if you like, in the periphery if this fiber is hit by a lesion or a disease, so neuropathic pain? So and this is animal experimental work which has clearly shown that there is a change in the expression of channels and receptors at the membrane of the pain fibers induced by the nerve lesion. And in particular, important are sodium channels, here in blue, and the TRPV1, the transient receptor potential vanilloid 1 receptors, which you see over here, which are highly expressed, induced by the nerve lesion. So normally these channels and receptors are not present, or very, very few of them are present on the membrane of nociceptive fibers. But under these pathological conditions, they are highly expressed in the periphery. And we now know that this is likely linked to specific symptoms, which we were mentioning before. And this is the attacks, mainly induced by the sodium channel expression, overexpression, these shock-like, electric shock-like attacks, and the burning sensation, which we also mentioned due to the overexpression of TRPV1 receptors in the periphery. We call this the concept of peripheral sensitization. So these neurons are sensitized and they develop ectopic activity. That means that they start to fire constantly action potentials to the spinal cord. So this is ectopic activity, spontaneous activity. So this is the bad side. So the underlying molecular mechanisms leading to pain or specific symptoms. But there's also a good side, because we can specifically attack these channels and receptors with drugs and medications. For example, we can attack the sodium channels with lidocaine and the capsaicin channels with capsaicin. And there are topical formulations available which we can use, and I've shown you here some examples. So this is a patch, sodium channel blocker, a lidocaine patch, which is approved for post-herpetic neuralgia, at least in Europe. And this is the capsaicin patch, which you can also apply topically. And just to remind you, this is only acting in some millimeters in the skin to calm down these neurons in the periphery. So it's no uptake in the system, in the blood, and therefore we do not have any interactions with other medications and no systemic side effects, which I think is very nice. So just some examples. The lidocaine, the topical lidocaine, which we have available, is again approved for post-herpetic neuralgia, but there's evidence for other neuropathic pain states as well. You have to apply this for 12 hours, and then you have to give the skin a 12-hour rest. It's a 5% lidocaine in the patch, and again, no interactions, no systemic side effects. Very similar, the capsaicin, which is approved for peripheral neuropathic pain, for all the peripheral neuropathic pain states, as Ralf Baron mentioned here in Europe. It's 8% capsaicin. And the interesting thing with this application type is that you have to use one application for half an hour or an hour, and then you have a reduction of pain for up to 3 months. So one application and reduction of pain for 3 months. This is, I think, a very interesting application way. Okay, so the next mechanism, the rational mechanism, which we should know, is a central mechanism. And this is what I call the calcium channel expression mechanism. So just, you know that if you have a barrage of action potentials from these peripheral fibers, from these nociceptive fibers to the spinal cord, there is a change in sensitivity in the spinal cord as well. We call this central sensitization. So these second-order neurons are sensitized secondarily. And if central sensitization is present, then A fibers, the blue ones over here, which normally convey non-noxious stimuli like touch or vibration. So these are the myelinated A beta fibers, for example. Was that for me? No.
No, that was Oksana microphone.
Oh, sorry.
Oksana, okay. Okay. So the activity in these fibers may gain access to these nociceptive second-order neurons, and then this is the mechanism behind mechanical allodynia, for example. So if you touch the skin, you activate these A fibers, and via this route, you will can activate the second-order neurons in the pain system, and this is then felt in the central nervous system. And we now know that in the mechanism of central sensitization, calcium channels are involved. And this is all the green calcium channels in red here in animal experimental work, which is upregulated on the endings, the terminals of these fibers, of the nociceptive fibers in the central nervous system. So calcium channel upregulation in the central nervous system is involved in central sensitization and leads to evoked types of pain like mechanical allodynia. And again, we can use this mechanism of pathophysiology to target these specific channels. And we use medications like gabapentin and pregabalin, for example, because they are calcium channel modulators, and therefore we can reduce the central sensitization in this particular area, and we can reduce phenomena like allodynia. So what is the evidence for pregabalin, for example? There's lots of evidence in the peripheral neuropathic pain states like post-herpetic neuralgia, polyneuropathy, but also in the central pain states, there's some evidence. And you see here the dosage which is recommended and some important information about side effects. For gabapentin, again, a calcium channel modulator. This is licensed for peripheral neuropathic pain states. Lots of evidence here. And you see the dosage which are recommended and so forth. So in the last bit of mechanism which we should address and discuss is the descending control systems. So normally in all of us, we have some descending pathways coming from the brainstem over here to the spinal cord over here. And these are modulating pathways. And you see a green pathway which is going down. And this is, as I always say, the good one. The transmitter is noradrenaline, and this is an inhibitory pathway. So if you activate the green one, you inhibit the transduction of pain through the spinal cord over here. And the other, the purple one, contains serotonin as a transmitter, and this is a facilitatory pathway, which enhances the transmission through the spinal cord. So with this normally physiologically present pathways, you can really modulate the pain transmission through the spinal cord. And under physiological circumstances, both pathways are equally activated. But what happens in a neuropathic pain state, and you see this here. So if the arrow is going to neuropathic, then we have an inhibition of these green fiber. So these fibers is weaker and weaker and weaker, this fiber tract, and this was the good one. So then there is a predominant activation of the bad facilitatory pathway, which clearly then leads to more central sensitization and transmission through the spinal cord. So you can also demonstrate these in functional MRI graphs today, showing that these areas in the brainstem, the bad facilitatory areas which project down to the spinal cord, are highly active in nociceptive pain states, leading to central sensitization. But again, you can manipulate the system by using drugs which act primarily here on the noradrenergic reuptake. And these are reuptake blockers, inhibitors, like the antidepressants, in particular the tricyclic antidepressants, which lead to a blockade of the reuptake of noradrenaline. Then you have more noradrenaline in front of your synapse, and this will lead to more and more inhibition of this system. So this is the mechanism of action of antidepressants in chronic pain, and in particular in neuropathic pain. And again, there's lots of evidence for this, for the antidepressants. And here I'm talking about the tricyclic antidepressants in many, many peripheral and also central neuropathic pain states. And you all know the titration, the recommended titration. So this brings me to a summary of this part. So what I wanted to show you is that we have lots of different underlying pathophysiological mechanisms in our patients, and we can address these mechanisms independently. We talked about some oral and systemic medications, so antidepressants, for example. We talked about anticonvulsants, which act on the calcium channel, which is gabapentin and pregabalin. We talked about anticonvulsants or sodium channel blocker like lidocaine. We didn't talk about the opioids today because they are really third line medications now in the guidelines, which I will show you at the end. We talked about some topical therapy approaches with lidocaine and capsaicin patches. And you can use combinations in particular with the systemic and the topical therapies. But in all these guidelines, there are no NSAIDs, no classical non-steroidal drugs, classical analgesics, but because there's no evidence that these drugs are working in neuropathic pain states. So now some ideas about the new, so the personalized treatment of neuropathic pain, the strategy which I already mentioned. So just imagine in your clinical practice, perhaps tomorrow, you see two patients with painful diabetic neuropathy. Diabetic, let's assume. And one patient, the one says, well, I'm suffering from thermal hyperalgesia, mechanical hyperalgesia, and allodynia, all these evoked types of pain. So if you touch my skin, this is extremely painful, and so forth. Okay. The other patient, exactly the same etiology, it's diabetic painful polyneuropathy. He says, well, I have something completely different. So I'm suffering from burning. It's a spontaneous burning sensation, but my skin is not hypersensitive, it's hyposensitive, it's numb. So you can do with whatever to my skin, it's not hurting. And I have hand crawling as well. So and if you see this, I think you immediately think that there should be different underlying mechanisms operating in these two patients, although they have exactly the same etiology. And if this is true, then you should perhaps treat these different types of patients differently. And therefore, we thought perhaps we can distinguish these two groups of patients with sensory profiling to use a technique which we call quantitative sensory testing, so a test of the sensory qualities, which we mentioned here, to profile our patients. And in fact, this is the protocol, the German protocol of quantitative sensory testing, which we established together with Rolf Baron many years back, where we use different sensory stimuli, and most of them we discussed already in the patients, to profile these patients as precisely as possible. And now we also have a bedside form of this, because the quantitative testing protocol is expensive, it's time consuming, but we can do it on a bedside as well. And we have invented some tools, as you can see here, for the bedside testing. We call this Fiber Assess, which you can read here, which is published. And what we did is we used in all the European countries which were involved, so this is a big network approach, a European network, where many of the labs on neuropathic pain were involved. We used these sensory testing protocol, exactly the standardized sensory testing protocol in all the patients in our labs. And there were many neuropathic etiologies, so polyneuropathies, zoster, and radiculopathy. We put all these patients together from all over Europe in a database. You see this here. Then we did the sensory testing in all of them. And then we used a statistical trick. We used hierarchical cluster analysis, which is a pattern recognition technique, to sort them, to identify different subgroups of patients. So we clustered them, and you see the different groups of patients. And these are the results which we found with the QST. There are some patients, I do not want to go into detail, the red ones here, they are dominated by thermal hyperalgesia, and therefore we call them thermal hyperalgesia subgroup, the red one. And there's another one. This group is characterized by sensory loss. Just remember our patients in the practice. No evoked phenomena here, but also in the negative range, the sensory loss. And then there is a third group, we call it mechanical hyperalgesia, which is dominated by mechanical hyperalgesia. So this is pinprick hyperalgesia or even allodynia. So 3 different groups of patients across all the etiologies we included with entirely different sensory profiles. And now we can speculate about the mechanism as well. And we call this is the fingerprint, the quantitative sensory testing fingerprint of our patients. And just for the thermal hyperalgesia, we think that this upregulation of receptors and channels we were discussing earlier is the major underlying mechanism of pain generation in this group of patients. If you look in the mechanical hyperalgesia group, so there we think there's a degeneration of C fibers because there was a loss of the small fiber range, which also leads to a central sensitization. And then, as we mentioned earlier, the A fibers may gain access to the system, which leads to the mechanical hyperalgesia, which is obviously the dominating sensory phenomenon in this particular subgroup. And now, and this is the most important thing, the first clinical trials have been performed in these subgroups. And I just would like to give you some examples to show that clearly the subgroups can respond better to a certain therapy than other subgroups. This was a trial with a TRPA1 antagonist. This is a transient receptor potential A1 antagonist, which was performed in a cohort of diabetic painful neuropathy patients. And you see here in gray, always the placebo, and here the active. And this drug is performing very nicely in the subgroup of thermal hyperalgesia, whereas if you look at the entire group of patients, this is the gray one, there was no statistically significant distinction between both. So again, the subgroup is responding nicely. Very similar, a different trial with oxcarbazepine. You see here, again, the hyperalgesia subgroup, nice separation between placebo and the active, and only very little in the blue, the sensory loss group. And these were the 2 subgroups which were compared in this trial. And this is a trial with pregabalin in traumatic peripheral neuropathies. And you see the green one is the one, so the mechanical hyperalgesia, which responds very nicely, whereas the blue one over here doesn't do the trick very well. So I think clearly the first studies underpinning the idea and the hypothesis that this is true, that we can identify subgroups of patients with sensory profiling which respond better than others. This is the approach we used. Okay, so the second new one, which I really, because I'm a neurologist, I'm really interested in, is the disease modification. So we have learned that neuropathic pain is due to a lesion of a neuron. So if it would be possible to induce a disease modification, so induce a regrowth of nerve fibers, for example, in our patients, a regrowth of healthy nerve fibers, then this would be a causative treatment approach, disease modification. And there's first evidence that the drug capsaicin, the topical capsaicin patch, is able to induce a disease modification. So this one is performed by Praveen Anand in London. And he used skin biopsies, and you see the skin biopsies here, and I got this from Claudia Sommer. These nice graphs. These are pain fibers in the skin, in the epidermis, and you can stain them and count them. And Pravinanand did exactly the same. He looked at the intra-epidermal nerve fiber density. You see here the control values. So this is normative data, normal patients, normal people. This is the number of fibers before the treatment with capsaicin, and this is the number of fibers 3 months after the capsaicin treatment. And you clearly see an increase in the fiber density in these 3 months. And this is a cohort of very stable chemotherapy-induced polyneuropathy patients. So indicative of regrowth of fibers, a regeneration of fibers, increase of fibers as compared here with the baseline characteristic. We were interested in a very specific subtype of C fibers. These are the so-called peptidergic C fibers. And the peptidergic, they are TRPV1 positive, and they are involved in the flare reaction and the axon reflex flare reaction due to the release of CGRP, calcitonin gene-related peptide, at the endings of these branches of the neurons. So if you activate these fibers, you can induce a vasodilatation around the activation site. And this is a neurogenic vasodilatation induced by the peptide CGRP, and therefore it's a peptidergic C fiber. And what you can do, you can measure this particular function of fibers if you measure the vasodilatation capacity. And you see this here. This is a laser Doppler, and we stimulate here in the middle of this area, these fibers, and you can measure the vasodilatation. This is the first peak over here, which is clearly an indicator of the function of peptidergic C fibers. And since we think that these peptidergic fibers are specifically important for the generation of neuropathic pain, therefore, we were interested in these fibers in particular. And we did exactly the same approach as Pravinanand in London did. We looked at the function of these fibers and controls. We did it pre-capsaicin in neuropathy patients with neuropathic pain. And then we induced degeneration with capsaicin. You know, there's a reduction in fibers already, I think, 3 days after the application. And then there's a regrowth of these fibers. And we could identify the regrowth already 4 weeks after the capsaicin application. And this was correct for the responders, for the pain responders. So the patients who really responded well at this marvelous regeneration. And our hypothesis is that this is the situation before the capsaicin. We have some fibers which are hyperactive, these red ones. Some are degenerated, it's a partial nerve lesion. Then you apply capsaicin. This leads first to a retraction of the fibers due to the capsaicin. And already 4 weeks after the application, you see a regrowth, an ingrowth of these fibers into the skin of healthy fibers. They are not sensitized anymore because these were pain responders. They were pain-free at this 4 weeks after the treatment. So again, indicative of a regenerative property of capsaicin in this particular setting. And I think this is really interesting to mention. And the very last bit are the killer cells in chronicity, which I think is very new and you should know. So what we did, we looked in patients with neuropathic pain with the so-called FACS analysis in the cerebrospinal fluid of these patients for natural killer cells. That are these CD56 positive cells in the CSF of chronic pain patients. And we could clearly demonstrate a very nice correlation between the counts of killer cells in the CSF and the parameters of central sensitization and chronicity. And as you can see here, the more killer cells you have in your CSF, the less, the smaller the likelihood is that you develop central sensitization and chronicity. So the killer cells are protecting you of a chronicity of your pain. And this is very interesting because there are very brand new animal experimental data showing that killer cells are recruited in nervous tissue to clear the damaged neurons. So it's if you think of a partial nerve lesion, the killer cells will eat the partially damaged neurons, and therefore you can reduce your pain. So I think it's a very new and interesting idea that inflammatory processes mediated by these blood cells might be involved in chronicity. So the last bit are the oxalate. This is relatively easy for you, I think, to use conventional analgesics. We have mentioned this for the treatment of neuropathic pain. You shouldn't use SSRIs for the pain treatment. So the selective serotonin reuptake inhibitors, there's no evidence whatsoever for these drugs. You should indicate topical treatment only in peripheral neuropathic pain states. So it's obsolete to do this in central pain states because the mechanism is obviously in the central nervous system. You can't reach them with a topical treatment. And you shouldn't recommend opioids as first or second line. They are always third line in all treatment guidelines. And you see exactly these in the guidelines, which were published by Nana Finderup and Lancet Neurology some years back, which we mentioned here. SSRI is not for pain treatment, topical not in central pain states, and opioids not recommended as first and second line. Yes, and with this, I'm at the end of my talk, and I would really thank you again for having me there